Thanks everyone for being here today. I want to say good morning. My name is Charlie Linticum. I'm the Director of Operations for the Virginia Opioid Abatement Authority. I'd like to welcome you to this installment of OAA's Abatement Academy. The Abatement Academy is a series of webinars that present best practices in opioid and substance use abatement strategies and highlights efforts being funded with opioid settlement funds in Virginia. Our speakers generously give their time and expertise to present these sessions. Like all Abatement Academy webinars, today's session is being recorded. Both the recording and the presentation will be uploaded to the OAA's website, and an email will be sent to everyone who is registered, providing a link to those materials. If you have any questions or comments, please type them into the Q&A box. As moderator, I will screen the questions and pose them to the presenters at the end of the presentation. Today's presentation will focus on emergency room bridge programs and hospital naloxone take-home programs. Our presenters this morning are Jason Lowe, who is the Addiction and Recovery Treatment Services Program Manager, or the ARTS program, as you may know it by, in the Behavioral Health Division for the Virginia Department of Medical Assistance Services, which is the state's Medicaid agency. ARTS provides substance use disorder services and recovery support to over 160,000 Virginians annually. Jason earned his master's of social work degree with a focus on administration and policy from VCU. He has 20 years of behavioral health experience in the public sector, having worked for multiple state agencies in Virginia. His primary subject matter expertise is substance use disorders, harm reduction, and policy development. He created and developed Revive, Virginia's naloxone distribution program, and one of the first state-level naloxone distribution programs in the country. Also, today, we have from the Carilion team, Drs. David and Cheri Hartman, who are employed at Carilion Clinic's mental health department in Roanoke, Virginia. They played a key role in developing Carilion's office-based addiction treatment program. And they both serve on the faculty of the Virginia Tech Carilion School of Medicine and co-founded Carilion's ED Bridge and Treatment Program with Dr. John Bertman. Dr. Cheri Hartman has served as the Virginia ER Bridge Treatment Expansion Project Lead. She's conducted evidence-based program replication in the fields of teen pregnancy prevention, substance use disorder treatment, dropout, and violence prevention among adolescents, as well as leading the quality improvement study of Carilion's ER Bridge to Treatment Project. Cheri convenes and provides trainings on ED Bridge best practices and plays a key role in grant management for this project. Cheri has a PhD in educational psychology from Temple University and has mentored medical students and residents in health systems, science, and research. And Dr. David Hartman is boarded in psychiatry, sub-certified in addiction medicine, ex-waivered for 16 years. He brought medications for opioid use disorder to Carilion, researching key outcome measures like treatment retention, ED Bridge, transition outcomes, benefits of MOUD on prenatal care, and the Start Now manualized group therapy impact on patients' treatment. David's provided trainings on medications for opioid use disorder for the Virginia Tech Carilion School of Medicine, statewide ECHO sessions, and the ED Bridge webinars funded by the OAA. David's provided clinical training for medical students through their clerkships, supervised residents, and fellows in psychiatry and addiction. And also from VCU, we have Dr. Brandon Willis, previously an emergency physician and medical toxologist, and who is the fellowship director for the Addiction Medicine Fellowship and medical director of the Motivate Outpatient Substance Use Disorder Clinic at VCU Health. From there, I will turn it over to Jason.
Thanks, Charlie, and good morning, everyone. Appreciate all of you joining us today, and I'm honored to be one member of such an esteemed panel of presenters, some real pioneers in this field, and so really appreciate being part of this and having the opportunity to share a little bit more about the work that we've been able to do together with the Opioid Abatement Authorities. Charlie, next slide, please. Just a little bit of a reset about Medicaid and why the role that we play as part of the continuum of care for substance use disorders in the Commonwealth. And just a little bit of clarity, Medicare there is a difference between Medicare and Medicaid. So just to level set there, Medicare is a federal health insurance program for those over 65 and some under 65 with certain disabilities or conditions. While Medicaid is a joint federal and state program that provides health coverage to eligible individuals with limited income and certain other specific populations. And Medicaid is the single largest payer of behavioral health services, both nationwide as well as in the Commonwealth of Virginia. Next slide, please. So how did we get started at DMAS, State Medicaid Agency, working with the Opioid Abatement Authority and as part of Bridge Clinics? So in 2019, we received a grant from the Centers for Medicare and Medicaid Services as part of the SUPPORT Act, which was the Substance Use Disorder Prevention that Promotes Opioid Recovery and Treatment Act. Now, this act contained a number of components, one of which was a grant program that was overseen by Centers for Medicare and Medicaid Services, commonly referred to as CMS. Virginia was one of 15 states that was awarded funding to carry out Support Act grant activities, which primarily had two focuses, or two focal areas. One was expanding treatment capacity, and then the other was expanding our workforce. As we were lucky enough to be able to partner with both of my colleagues that, or all of my colleagues that are on the call today, through the Support Act grant, we partnered with Carilion Clinic in Roanoke, represented by Dr. Wills, and I'm sorry, by Drs. Hartman, and Virginia Commonwealth University, Richmond, which is represented by Dr. Wills. Sorry, I haven't enough coffee yet. Next slide. And so what we did, what we were able to support in Roanoke at Carilion Clinic was the expansion of Bridge Clinic services, adding staff, including social worker and a peer recovery specialist, and partnered with and supported Cheri and Dave in the development of an implementation curriculum in partnership also with and with support from the Virginia Department of Health. So we were all able to, VDH and DMAS were both able to lend support to Carilion as they develop this curriculum that is currently being utilized by hospitals and health groups throughout the Commonwealth who are interested in or actively involved in implementing these kinds of clinics within their organizations. Next slide, please. At Virginia Commonwealth University, we were really fortunate to be able to work with Dr. Wills, who's pictured there, as well as Dr. Jerry Muller and a lot of other important staff at VCU in helping them to implement their Bridge Clinic. And because of their hard work, they were able to interact with more than 500 individuals post-overdose and link them to community-based treatment options. And the really important thing to note there is that that linkage is not just an appointment card with a date on it. What we're able to do is really strengthen that connection for the individual so that if the individual was interested in pursuing their recovery, they have an appointment set up, they have everything ready to go. All they need to do is show up at the community-based treatment provider, whichever that may be. That really is the core of the Bridge model is, if an individual is considering their recovery, if they're pre-contemplative or contemplative in terms of that, we want to remove as many barriers as we possibly can for them to be able to engage their recovery journey. And so allowing them to have a scheduled appointment, allowing them to have access to Naloxone if they decide to continue to use substances, whichever the case may be, however we can support that individual, whether they're pre-contemplative and still using substances, or whether they're contemplative and looking at engaging their recovery. Wherever they are in that journey, our goal is to support them and help them make the healthiest decisions that are the right ones for them to make. And so that was the work we were able to support at Virginia Commonwealth University. Next slide, please. So how's it going? Where we are today, and just in the last year or so, um, as soon as the Opioid Abatement Authority was offering opportunities for states to apply for funding, DMAS was applying for that. And our goal really is to do a couple of things. We talk to a lot of hospitals throughout the Commonwealth, and there are some upfront challenges about implementing these kinds of programs. It's a pretty heavy administrative lift. You have to do a lot with your EHR to have that interoperability between the EHR in the ED setting and the EHR for the community-based provider. Those are expensive modifications to make sometimes. And so what we discovered was that what would be really useful was funding to the hospitals to help be able to uh, defray those costs. The other things that we really wanted to look at doing were providing targeted technical assistance to hospitals that might need it, and utilize the resources and the knowledge that we have, um, courtesy of the real pioneers that are on this call today, as well as others. And then some more general efforts to reduce stigma around substance use disorders, as well as education around the importance of the bridge clinic model and the impact of the bridge clinic model, and how successful it has been, and the kind of changes that it has made for our members in the Commonwealth, as well as individuals in other places around the country. Next slide, please. So we were very fortunate to be awarded funds from the Opioid Abatement Authority. The first year we requested and received $150,000, but unfortunately, due to a number of delays, a number of issues, we had to delay implementation of the project, which was pushed back to the 2024-25 period of performance, which runs from October to September. And in 2024-25, which we just finished up, we carried over that $150,000. We contracted with our friends at Carilion Clinic, and they provided 10 webinars that were attended by more than 900 professionals throughout the Commonwealth that touched on a variety of topics related to substance use disorders and emergency department bridge clinic programs. Next slide. So where we're headed, we're really, really excited at DMAS about where we're headed. This past year, we applied for and received additional funding to be able to provide those incentives to hospitals who are interested in implementing this work, but may need some additional resources, may need some additional training and technical assistance. And so for this period of performance that just started October 1st of this year, we were awarded $1,050,000, which gets broken up as you see there on the slide. $900,000 of that is funding to hospitals and health groups. We are currently working on a request for applications, which hopefully will be released later this year. Our tentative plan is to award between 2 and 4 awards to hospitals, depending on the proposals that we will receive. I don't have any information beyond that. I don't have any details yet to share about the RFA, but I will certainly share my contact information here. Charlie has it as well. If you're interested, please feel free to reach out to me or our team inbox, and we can definitely put you on a list to make you aware once the request for applications is released, which will again hopefully happen later this year. And then we intend to continue our partnership with Carilion to continue and provide that training on stigma reduction and bridge clinics, as well as provide that specific technical assistance to our awardees to help them with their implementation of the programs in their settings. Next slide, please. And so we continue to, our goal was to continue to make similar requests to the Opioid Abatement Authority in the future for similar funding. And so our goal is if we receive those awards, we will have ongoing cohorts of hospitals that we will be working with. How many a year depends again on the number and type and quality of applications that we receive. But we are intending to apply for these funds to continue to do this in subsequent periods of performance. We're going to be working with our evaluation partners at Virginia Commonwealth University to ensure that our projects are successful. We're working with research partners to identify opportunities for growth or other areas where we can address the needs of our members with substance use disorders. And we will also be looking at our outcome metrics, which I didn't include, but we'll also be looking at how we measure the success of, or the progress of the program for our members as well. We are also shifting our language a little bit as a result of some work that we've already done. We now refer to these programs as what we call our discharge bridge programs. So we see this as affecting individuals not only discharging from the emergency department, from other setting, but also from other settings within the hospital. And so we have started referring to it as our discharge bridge program as opposed to our emergency department bridge program. Next slide. I think that's it for me, other than to say it's an honor to be co-presenting with all of the fantastic folks that you're getting ready to hear from, and want to sincerely thank the OAA for their partnership and look forward to continuing to work with my co-presenters, the OAA, as well as some folks maybe on this call in the future. So thank you again, and I'll turn it over to Dr. Cheri Hartman. Cheri.
All right. Thank you so much, Jason, for all that you have done for our programming. And also thank you to Charlie for your kind introduction, and to the Opioid Abatement Authority for making this work possible. We're very passionate about the work, and we really appreciate this chance to expand it across the state. So next slide, Charlie. This introduces a summary of Dave and myself, but also a key member of our team that I want to especially recognize. If you do become, one of the awardees, or you are someone who is just interested in learning more about our ED Bridge expansion program, you are most likely to have contact with Gabe Anderson. He is one of those unsung heroes that makes so much possible, and yet isn't front and center getting the credit for it. But I do have his contact information included in this presentation for you to be able to reach out to him if you are interested. At Carilion, they do allow married couples to work together. So Dave and I did have that privilege of starting the addiction treatment clinic based on the arts initiative led by DMAS. And the marriage has survived all of this togetherness. That's the good news. Charlie, next slide. We'll move on to the why behind our work. Jason has given you an overview about some of the elements of the ED Bridge. I'm sure everyone on the call is quite familiar with the impact of the opioid epidemic. It did hit us especially hard in Roanoke, Virginia. And what we find especially tragic about the opioid epidemic is that this chronic yet progressive disease that ultimately can be fatal is treatable. And the Arts Initiative actually made it possible to provide affordable, comprehensive, integrated care that's effective. And yet, only about 20% of persons with an opioid use disorder actually access the treatment. And so today we'll talk about leveraging the emergency room as a pivotal point, a touch point for helping people get on the path to recovery. And we do find it is quite effective. We also know that it is primarily the untreated who overdose. So if we can get people into treatment, this is an important part of the solution. So we know, I'm sure all of us, that fentanyl's been driving the fatalities to these really tragically high levels. But we're encouraged that we're seeing a decline recently in Virginia, as well as across the country. But I like to quote Dr. Petros Livanis, who's a past president of the American Society of Addiction Medicine, when he stated that the current state of addressing the opioid epidemic is far from doing well. When nationally more than 82,000 Americans are losing their lives in a 12-month period from drug overdoses, and overdoses remain the leading cause of death among 18 to 44-year-olds. Next slide, Charlie. This chart shows that trajectory, of the increase in fatal overdoses in Virginia right up to the pandemic, and then the recent decline. But you can see in the final column, we are projected in 2025, by the end of the year, to have lost over 1,500 Virginians. So as Dr. Petros Livanis says, we still have a long way to go to effectively addressing the opioid epidemic. Next slide, please. So what's driving these fatalities is the prevalence of the disease. So these are estimates, of course, of people with opioid use disorder nationwide. It ranges anywhere from 2 million to 6 million, or 6% to almost 2%. The professional, most reliable resources lean toward the higher numbers on this. Virginia's proportional share is 55,000 to 150,000, again, with 150,000 probably closer to an accurate number. Estimates are, sadly, that it could be as many as 80% are receiving no treatment in the past year for their opioid use disorder, which can be managed when in a clinic, a treatment clinic. Some 20,000 may be incarcerated at any one time. And this is a list of the higher risk groups, ages 25 to 64, males more vulnerable than females, or Black population more vulnerable than other populations. Persons recently released from the emergency room are especially vulnerable. Persons discharged from the hospital are especially vulnerable. And we also are concentrating on bridging our patients from the hospital using similar best practices as we use in the ED. And then also the incarcerated are multiple times more vulnerable than other populations, as well as our polysubstance users. Next slide, please. The good news part of the story is that it is treatable. We have had such rewarding benefits of treatment from our clinic, which inspires us to try to help more people access the treatment clinics. In Virginia, thanks to the Arts Initiative, we've worked with Jason for many years and his predecessors, and thanks to the policies that were put in place and made available in 2017, we have created over 200 best practice clinics throughout the state. So that's the good news. We have loved seeing the proliferation of more clinics right here in Roanoke and throughout the state, but this increased capacity has not put a lid on the opioid epidemic. Again, too few are getting into treatment. Next slide, please. So in 2018 is really where the ED Bridge story begins for us. The OBOT here, Office-Based Opioid Treatment Clinic, was well established by then. Dr. John Burton knew about our clinic as chairman of the emergency medicine department. He attended a conference that featured Dr. Gail D'Onofrio, who shared her seminal research on what she called STIR, which stands for Screening, Treatment Initiation onto Buprenorphine, and Referrals, providing rapid access to follow-up care. And part of what Jason talked about, rapidly getting people into a treatment program. So this is where our story takes off. Next slide. Dr. Burton went to the conference and came back so inspired by the compelling findings of Dr. D'Onofrio's research. He wanted to start it like next week, which was Christmas. And, we did gather a team together and get this bridge up and running because, to look at the data, how could you not, right? What Gail D'Onofrio found is that her patients with opioid use disorder who were identified as being in withdrawal were initiated onto buprenorphine. They got motivational interviewing and then an effective discharge process, rapid referral, and 78% of those patients got into follow-up care, where prior to that, at best, had been, much, much lower. When it was compared with control groups in her study, with motivational interviewing and referral, 45% got into follow-up care. And when they had the referral alone, 37% got into follow-up care. Next slide, please. So you can see, it was quite astounding to have this level of success. And we wanted to, leverage that model here in Roanoke. The American College of Emergency Physicians were so impressed with the research, they officially issued a recommendation that emergency physicians offer to initiate opioid use disorder treatment with buprenorphine with appropriate patients and provide direct linkages to ongoing treatment. Next slide. So I'm going at this point to turn the story over to my husband, Dr. David Hartman.
Hello, it's an honor to be part of this panel, and I thank you. I wanted to clarify up front that I'm totally blind, and I have a machine that makes a little noise. I also have a service animal who tends to snore. So if you hear snoring, it's not Cheri, it's our animal. So pre-2018, we noted that there seemed to be a lot of tension between the emergency room doctors and patients with opiate use disorder. The tension was that the emergency room doctors had concerns about these individuals in withdrawal, and yet they didn't know what to do for them. They weren't sure what to give them to support their pain and agony, whereas the patients who were in withdrawal were in a lot of discomfort and they wanted help immediately and were frustrated. And there was a lot of game playing. Some of the patients actually would do things to hurt themselves. I had one patient pouring boiling water on his leg so that he'd have an obvious reason to get an opiate. But there was a lot of distrust, a lot of dishonesty, a lot of manipulation going on, and the physicians and patients were at odds. Next slide. So in 2018, as Cheri mentioned, Dr. Burton, the chairman, decided that he was going to have about 50 of his emergency room doctors waivered, and therefore going through the training to become prescribers for buprenorphine naloxone. And what they did was they would contact the PMP, they would evaluate the patient. If the diagnosis was opiate use disorder, they would often give them buprenorphine naloxone right there in the emergency room. And then they would also give them a prescription. One of the problems that the emergency room doctors struggled with was the fact that they had nowhere to refer these individuals once they started them on buprenorphine naloxone. And so we in the opiate outpatient treatment program, we would see them within a week. We promised that we would make sure these individuals got into care. There also were peers that worked with these individuals, getting them into our program. So, next slide. Fears were that the emergency room at Carilion would become the center of getting buprenorphine naloxone, and anybody that wanted it would come to our emergency room. People from all over Virginia, West Virginia, and elsewhere would find their way to our emergency room, and we'd be overwhelmed. We would have tremendous rise in costs, and then the emergency room doctors would not know who to send these individuals to. And a lot of individuals, a lot of administrators were worried that this was going to be a disaster. Next slide. What really happened was fascinating. What you found was that individuals came to the emergency room, got their buprenorphine naloxone for their withdrawal. They felt more satisfied. They felt heard. They felt trusted. There was better communications between patients and the physician. The physician now had a tool in which they could help these individuals with tremendous pain and discomfort. They also had a place to refer these individuals once they treated them. And so the result was lowered costs. Less patients utilized the program. There was a lot of trust built between patients and the doctor. And the patients were more likely to get into treatment. And as I said, less likely to come back. Thus, there was a reduced cost. So what we're finding is that a protocol has been developed where—
Next slide.
I'm sorry, next slide. Protocol that's been developed where when a patient with opiate use disorder appears in the emergency room, the emergency room doctors will evaluate them and make the diagnosis. And I won't go into the diagnosis, but they would diagnose opiate use disorder. They would assess their level of withdrawal with the COWS, the clinical opiate withdrawal scale. And if it was 8 or above, then they would be given buprenorphine naloxone. They would check the PMP. They would connect these individuals with peers and then refer them to our clinic. Now, since then, there have been a number of clinics opened in our area, and it's easier to get them in the treatment into outpatient programs. The question, do we give methadone? Yes, if the patient was on methadone, preferred methadone, we would provide methadone. But buprenorphine naloxone is a very safe medication to work with. It works by adhering to that mu receptor. It has a strong adherence to that receptor and therefore provides some protection from an overdose. It not only helps cravings and withdrawal, but it also gives some protection. So the buprenorphine naloxone became the preferred medicine to provide treatment for these individuals. Methadone would be used, but again, methadone, you have to go every day to their clinic, whereas the buprenorphine naloxone, we could manage them within a week and get them stabilized in an outpatient program. We'll also ask, why not naltrexone? Naltrexone, the individual has to be free of opiates for at least 7 days, and so it wasn't very practical to use naltrexone in the emergency room. We find that buprenorphine naloxones may not need as much if the person has low tolerance. Maybe they've been incarcerated for several years, have a low tolerance. We would start at a lower dose. We also noted some people who came in and were not in withdrawal, and then we would give home induction. We give a prescription for a home induction. But we would try to get them into our outpatient clinic or to one of the clinics and get them ongoing counseling as well as medication.
All right. Do I take over at this point? Are you finished? Yes. Next slide. So the next slide shows the criteria that are looked at for diagnosing an opioid use disorder. And again, we're not going to review that, but that's part of the process. Is this diagnosis? Next slide, Charlie. So this slide shows the COWS, the clinical opiate withdrawal scale that Dave mentioned, that can be used to identify the level of withdrawal of the patient. And then you initiate them onto buprenorphine in order to treat the withdrawal symptoms. Next slide, please. And Dave has covered a lot of this information about why buprenorphine is so effective and recommended for ED initiation. I'll just put a fine point on dispelling one of the myths that we still encounter about buprenorphine. I think there's been so much distrust of opioids in general, and buprenorphine is a partial agonist. It is an opioid, but it has the ceiling effect. It is quite safe, and it is not substituting one toxin for another. It fact improves functioning, and that's the key difference between your street drugs and your prescribed medical buprenorphine, is that it improves functioning. It is getting a person on the path to recovery and actually frees up executive functioning in order to get one's life back together again. Next slide. So I wanted to highlight some of the findings of the quality improvement study that our funding from the state made possible. Basically, we tracked 3 types of patients: those who came in withdrawal level, either getting an 8 or above on the COWS, or having been clinically identified through, visibly seeing the withdrawal symptoms. The other is an overdose survivor who's been either revived in the ER or revived prior to being transported to the ER. And then third, those who are coming in seeking to initiate treatment. And so they might have recently used, they're not in withdrawal, and they have a slightly different protocol. Of course, they won't be started on buprenorphine if they have recently used, because that would put them into precipitated withdrawal. Next slide. So we studied the application of the protocol with these 3 types of patients. And we looked at how many patients in withdrawal were in fact administered buprenorphine in the ER and at what dose, how many patients were provided a prescription for buprenorphine, which is a big part of our model, is that medical bridge, getting the medical treatment that serves as a bridge between the ER and the follow-up appointment. On what dose, what is the duration of the script? Was it long enough? And did it in fact provide that medical bridge? And then how many patients were linked with a peer in the ER? That's how we support that important discharge process. Is we try to link most of our patients with a peer if they're interested. Next slide. The other thing that we followed in the next slide is a list of the outcome objectives. How many patients successfully crossed the bridge from the ER to that intake at the follow-up treatment clinic or provider visit? How many patients were referred to a higher level of care, because at times that was necessary, and how many patients remained in treatment for at least a month. Next slide shows a summary of the data across the first 4 years of our quality improvement study. We at first made the referrals directly to our own clinic. We were getting patients in within a day at times, sometimes even same day. And we could do that because we were right across the street from the ER, and Dave was willing to work through lunch. So, we had that direct access to our own clinic. As time went on, more and more clinics were developed in Roanoke. We're grateful for that. We didn't want to be the only, game in town, but it did make it harder to track the data later on. So the really impressive numbers at the beginning, 82% crossed the bridge, 78%, 71%, fell slightly as we were making more referrals externally. You might remember back in the day, there was this cap. Dave was approaching his cap, his limit on how many patients he could work with. So we did have some follow-up sites that shared data with us. Brightview, for example, indicated that 65% were getting into care at their site, but the availability of that data was pretty rare. So we haven't been able to track it quite as effectively to the external clinics. Next slide. Some of the key factors that we tracked in terms of their predictive power in predicting a successful transition included the initiation onto buprenorphine in the ED when the patient is in withdrawal and they get relief. They are highly likely to successfully get into follow-up care. Also, that peer support. Year 1, they actually doubled the chances of a successful transition. Each year since, they have had a statistically significant impact on supporting successfully our patients getting into follow-up care. The rapidity of access matters, and also training the ER physicians. That initial training of 50 Carilion ER physicians who got wavered, as Dave said, they got 8 hours of training, really changed the culture of the ER. Next slide. Want to not spend much time on this. This is the outline of what makes up an office-based addiction treatment clinic. Very exciting to have the Arts Initiative put forward a model of best practices where we had integrated psychiatry and addiction treatment. We had care coordination, helping patients get their lives back together, plus peers. Next slide. So now we are partnering with DMAS and VDH at the level of expanding this model across the state. We currently have in our cohort 7 early implementer healthcare systems. As Jason mentioned earlier, it's our goal to expand further. So we are, by way of expansion strategy, conducting these webinars. You're invited. Next one is November 18th. We offer these to hospital ER leaders and clinicians. Anyone interested can log on to learn the basics about addiction treatment, especially as it applies to the hospital setting. Next slide. This is a map showing our footprint to date. That is directly who's in our cohort. Of course, VCU is a key player in this picture, so we need to map onto this the impact of VCU as well because of their significant impact. But we get to work with and provide technical assistance to these hospitals represented on the map. And if you were to become an awardee, that's what we offer. We can do site visits, virtual trainings, technical assistance to support replication of the best practices. Next slide. We put together, we have materials that are a part of our ED Bridge training toolkit, like sample protocols, these kinds of decision trees that you can embed within the EHR. Next slide. This is the ED Bridge training toolkit. I call it training to go because it has these click and play links that you can access that are like Dr. John Burton himself getting to yes in your hospital system, and other kinds of sort of mini trainings are embedded within the training toolkit. Next slide. One of the click and play videos features Nancy Agee, our newly retired CEO of Carilion, who did a great YouTube on anti-stigma messaging. And we really recommend that a new effort like this be accompanied by anti-stigma education and messaging from top down in your system. Next slide. Finally, we offer the invitation to reach out to us to learn more about the ED Bridge. As John Burton says, it's not rocket science. They're just some basics that if you can adopt them, you can make this happen in your hospital system. So next slide, I think ends with the QR code, which gives you access to the ED Bridge training toolkit. We're constantly updating that. And I want to turn it quickly over to Brandon Wills, Dr. Wills, and let you do your presentation on the important work you're doing.
Thanks, Cheri. I will target 5 minutes, just so if everyone's running out of gas, give me 5 minutes and then we'll have some time for some Q&A. But this webinar has been fairly ED centric, and I'll just take the baton and stay in the ED for a little bit longer and talk a little bit about the Virginia Naloxone project, which has been a collaboration that we'll talk about shortly. And Ryan's on the Zoom here. I'll be talking about her role in just a minute, but I just want everyone on the Zoom to think for a minute what it's like to go to the emergency department with something like an ankle fracture or something like that. You go in, you get seen, you get an X-ray, And then you leave the emergency department after you've been placed in a splint and have some crutches. And then you have follow-up with orthopedics, the next week or the next day. But when you come to the emergency department, following a non-fatal overdose, you could be blue, an apneic, not breathing, and then 2 hours later leave the emergency department with nothing, maybe just a piece of paper that has some names of some clinics that you could go to if you wanted to. And that obviously just doesn't sit well with most of us probably on this Zoom, and know that we could do better. And I found out about the Colorado Naloxone project several years ago that Dr. Don Stater started. And that project was to equip emergency departments to provide naloxone in hand, to actually physically hand it to patients who are at risk for overdose upon discharge, and wanted to adopt that here in Virginia. And we did. And with the help of DMAS, funding from DMAS, VCU started a take-home program. And Carilion had done something similar with VDH funding. And so we kind of had these mini naloxone projects going on, but with the help of OAA, we've been able to operationalize that. And so that's what I'm going to briefly chat about. So next slide, please. Cheri already went over this, but the ED is a very special and important place to engage with patients with opioid use disorder, especially with those that have had non-fatal overdoses. About 5% of those patients will be dead within 6 months. And so that is a crucial time to begin the engagement process. Next slide. And so these are numbers that are based on some analytics that the Naloxone project created, but there's no shortage of emergency department visits where patients are identified as at risk for overdose. So there's clearly a need here. Next slide. And so some of the challenges are, just awareness of the process, and you can just go through these. And if you do write a prescription for naloxone, it will not get filled. The fill rates are extremely low. And the problem, unfortunately, unlike harm reduction sites and other outpatient venues, dispensing medications from the emergency department has some technical glitches due to pharmacy regulations that create some barriers. They're easily surmounted, but there are some barriers to prescribing. Next slide. And so this is the mission statement of the Naloxone project, and basically is we want naloxone to be available and given to patients at the time of their discharge. Next slide. And VHHA did a similar survey, and the bottom line is that most emergency departments do not have a take-home naloxone program up and running. Next slide. And so herein lies the collaboration. And so we basically we started this, I don't know, 3+ years ago, but it was almost dormant. It was just happening locally at VCU, and it's because we just didn't have all the right pieces in place, and through funding from OAA, we were able to get Ryan formally on board as our project manager, and what she's been able to do is really operationalize the naloxone project, the Virginia Naloxone project. And we're just kind of finishing phase 1, where we've created a toolkit and have signed up our first 40 emergency departments into the program. Phase 2 that we'll be going into this coming year will be to disseminate this more broadly across the Commonwealth, with ultimately the goal of having 100% of emergency departments able to dispense naloxone. And phase 3 is to identify ways that this will be sustainable outside of grant funding, i.e. Having payers pay for the naloxone rather than it be purchased through OAA grant funding. Next slide. And so I probably shouldn't have put all the animation in here since I'm not controlling it, but you can click through this. With the funding, a few key things have happened. We were able to get Ryan to dedicate her time to this project. We developed a toolkit that we give to hospital pharmacists, emergency department medical directors, and administrators to give them all the steps to legally create a take-home program. And then we actually provide naloxone kits to emergency departments. And this is a picture of me handing out our first kit at VCU. This was years ago. Next slide. And this is Colorado data. I just wanted to point out that with this Virginia Naloxone project, we're going to be collecting data, and you can get a pretty cool report that shows the number of kits that were dispensed here. This Colorado report shows 14,000 kits dispensed from emergency departments. And so hopefully in the years upcoming, we'll be able to have similar reports like this. Next slide. Keep going. And we can skip this one as well. So I basically wanted to just end there, and our next slide has contact information for both Ryan and myself. And anyone out there that wants to collaborate with us or develop a take-home program, we'd be happy to visit with you, and wanted to leave a few minutes for some Q&A at the end. So I'll end there.
Thank you. Thank you all very much for all the work you all are doing. We always appreciate the shout outs to the OAA, but if we can provide all the money in the world, if there's not people like you all out there to actually get these programs in place to provide the assistance and help to the people that need this, that were so impacted by the epidemic, then none of what we do would matter. So we'll open it up for questions. You can use the Q&A feature to type your question in. If you have something you feel is a little too complex, try to type out. If you use the hand raise function, I can use the allow to speak option, and you can ask it in the meeting. We do have one question that has come up. What is the biggest barrier preventing the adoption of the Naloxone project among healthcare systems with multiple emergency rooms?
Yeah, Ryan might be able to address that more than I do, but the barrier tends to be the electronic health record and the pharmacy processes, because it's easy for us to ship you a big box of naloxone. So it's it's really getting the key people. So it's the PharmD and the emergency department medical directors to be on board with it. And once they are, then they can push all the buttons to get the Epic builds or the Cerner builds to create the orders that are necessary to put it in your Pyxis or your Omnicell. So that's really the key piece. Ryan, I don't know if you're able to say any more about that.
No, you pretty much answered the question. I was going to say just buy-in and just convincing leadership that it is not a huge task, or at least it's a little bit of work on the front end, and then it should just be part of like a regular workflow. And for the beginning, we're going to be, providing that free naloxone for as long as we can. And then on the back end, working on ways to make it sustainable. So really just buy in, because we have all the resources and we are there to help you like every step of the way and make it as easy as possible. And then provide some data reports. We're working with some data institutes in Virginia to get at-risk visits. So we're going to do something that we did in Colorado, where we compare at-risk visits that come through the emergency department and how many kits are given out, to try to do a little quality improvement and get a sense of how many kits are going out to those at-risk visits. And then we can work with teams and do some additional training if those numbers are really low, and just really try to push naloxone and saturate our communities with it.
Thank you. Any other questions? It's the moment I always wish that those little three dots that show up when so many other things don't show up on Zoom's Q&A feature to let me know if somebody's typing something in. Oh, do we have a hand raise? Nope. No, you're welcome to use the hand raise function or type stuff into the Q&A. Right. Jennifer, you can go ahead.
Hi, yes, my name is Jennifer Haney. I'm a patient care director here for the Recovery and Wellness program at the Virginia Hospital Center. One of my curiosities is in what challenges have you experienced with some of the patients doing accurate self-COWS assessments in order to know when to initiate their buprenorphine treatment, home treatment? And have you had any challenges with precipitative withdrawal because of those self-assessment outcomes?
So David, do you want?
Yeah, I find that the patients have often experienced buprenorphine naloxone either off the street or they've been in programs, and they have a better sense than I do as to when the optimum time is to begin it in a home reduction. The other thing is we often educate them that if you do have precipitated withdrawal, the best thing to do is take another buprenorphine naloxone. So we try to educate them how to manage it. But I know there have been a few people that have had precipitated withdrawal, and it's very uncomfortable, and it can make them a little skittish about being on a buprenorphine naloxone in the future.
One other
Yeah,
thing we consider today is the impact of fentanyl. So that fentanyl being stored, in your body can lead to precipitated withdrawal. And you would be surprised potentially by that because maybe you didn't use recently. But we do instruct them, as Dave said, to override that with another dose.
And Jennifer, just to add to that, the vast majority of buprenorphine initiations that we do on the outpatient side are done at home, not in the office. And so we do not use self-COWS scoring. It is a subjective discussion with the patient. I have a home initiation handout that I give patients, and it's on a 1 to 10 scale. It's not evidence-based, but as David was saying, patients generally get the idea that they need to be very uncomfortable before they start buprenorphine. And so I don't think you need to focus too much on the actual numerical COWS score. That's more for clinicians.
I want to echo the comments of all of those folks and just add one other thing. I hear sometimes that there is a segment of people who use drugs that are very well educated in understanding buprenorphine, how it works, what it does, the different formulations. I do think there is also a little bit of misinformation, however, sometimes, especially when it comes to the different formulations, specifically the oral versus the long-acting injectable. I do think also sometimes some people conflate naltrexone, the injectable naltrexone, with the injectable buprenorphine if they're not as, if they're a little bit more treatment naive, if they're not as well versed in different treatment options. So I think it also does help to be really clear with individuals who are considering MOUD, to be clear about options, to be clear about which formulation you're looking at using, and what the potential impacts of those different formulations might be.
Can I ask one more clarification question, if you don't mind?
Sure.
Once the patient has initiated their buprenorphine, and then their insurance company, say, perhaps covers Subsolve, where you've had to do the conversion between dosage conversion.
Yeah.
How have you been able to manage that to support the patient?
I guess might be my
Go ahead, Dave.
Hi. Yeah, it is sometimes an adjustment going from the buprenorphine naloxone to Subsol, but I do find that it does transition easily. Sometimes I have to use a little more Subsol to make it as effective as their sublingual buprenorphine naloxone.
Thank you so much. I really appreciate your answers, and I absolutely adore this program. Having lost my son to an overdose, even after working in this field for the greater part of 25 years, I am very, very passionate and can't wait to help to start to partner a little bit more closely. Thank you so much.
Sorry for your loss.
Yeah.
I do have another question in the Q&A, and we have another hand raise coming. So in the Q&A, we have, what is the anticipated impact of the federal government shutdown related to these programs?
Well, my big concern, this is Cheri, is that we're going to have to step up care coordination pretty intensively if in fact, that you're going to have to document that you're trying to get a job and that you've gotten a job and so on. I think that it's going to take a lot more care coordination. I remember back in the day before we had Medicaid expansion and we were able to treat males, it was so hard to get our men to be able to afford treatment. So we're prepping and we need, I think, to be ready to intensify care coordination.
Charlie, I can't add much. I'll add what I can, which is basically to encourage folks to keep an eye on guidance that will come from CMS. So the primary issue right now is that because of HR1, CMS now needs to operationalize the items that are indicated in HR1. States cannot move forward with any of this work until CMS provides guidance to the states in terms of how these things should be done. That guidance is not required to be released until the middle of next year. And so I would ask for your patience and your forgiveness, which is pretty much all we can do, because without that guidance from CMS, we really cannot say anything. We can't start working on it until CMS operationalizes the components of HR1. And so just keep an eye out. It will be communicated as soon as it possibly can be by our state.
Thanks, Jason. We got we had one more question, but it looks like I might have lost them. We were running a little over time here. If anybody wants to raise a hand again for a final question. If not, you see in the chat, you can see some contact information for further follow-up and questions. And as mentioned earlier on the recording for this and the PowerPoint will both be emailed out to you all as attendees and available on our website on the Abatement Academy page. I'm not seeing anything else. We appreciate all of you all and your time and everyone attending today and look forward to seeing you on the next one.